Greetings, everyone. My name is Girija Shankar, and I'm the head of NTD programs at CBM Christian Blind Mission and serve as the chair of the NTDs NGO network. CBM envisions a world in which all people with disabilities enjoy their full human rights and achieve their full potential. We seek to reduce the prevalence of diseases that cause impairments and minimize the conditions that lead to disability. CBM has worked with partners at the global, regional, and community levels to support national programs in their efforts to eliminate diseases like trachoma, river blindness, and other NTDs for over 30 years. My CBM colleagues and I are thrilled to host this webinar on embracing gender equity in the fight against NTDs in the run-up to International Women's Day on the 8th of March. We brought together a diversity of voices, views, and expertise to this topic, and we hope that you will find this next hour enriching and insightful. We have a mix of keynote statements from leaders in South Sudan, Nigeria, and Germany, a framing presentation from Professor Margaret Japon, video messages from NTD practitioners, followed by a live panel discussion with opportunities to engage you, the webinar participants, in this conversation. Before we kick off, I'd like to walk you through some housekeeping rules. Please be aware that this event is being recorded. For questions and comments, please use the Q&A function at the bottom of your Zoom screen. Please indicate the panelist that you would like to answer the question. Closed captions can be enabled via the CC button. We recommend keeping it on throughout the webinar since not all videos may have subtitles. If you are following the live stream on YouTube, questions and comments can be sent to my colleague Miriam Meyer at cbm.org. And finally, thank you for sharing your comments in a respectful way that recognizes the diversity of voices represented here today. To kick off, let's enjoy this short message from NTD practitioners and colleagues working to beat NTDs in Nigeria.
One of CBM's strategy to eliminate avoidable blindness is by contributing to government's efforts to eliminate NTDs in endemic countries. CBM is conscious of the fact that NTDs disproportionately affect women due to their role as caregivers. As an NTD program manager, one of the things that motivates me is that it provides me an opportunity to design inclusive and equitable programs that prioritizes women and girls. Abeibu lives in the Amhara region of Ethiopia with her husband, son, and daughter Zainab. Until recently, Abeibu was suffering the effects of trachoma, which was causing her eyelids to turn inwards and making her eyelashes scrape painfully against her eyeballs. Left untreated, this condition can lead to blindness. Abeibu and her husband are weavers. It is their job to spin the yarn needed for the heavy white shawls they sell at the market. With her eyesight failing, this task was proving almost impossible. Trachoma is very infectious. Mothers and children are at high risk because they are often at home and in close contact with each other. Abeibu's daughter Zainab was also found to have trachoma, although it was at a much earlier stage. Zainab was treated by CBM with antibiotics that stopped the disease taking hold. Abeibu received surgery to halt any further deterioration of her vision. She was operated on by doctors who received training funded by CBM.
Why do you think women are vulnerable to NTDs?
Now, women are vulnerable to NTDs. One of the reasons is due to their social or their primary roles and responsibilities in the house. You see, the women are the ones that are the home front. They're the ones that go to the stream to fetch water. They're the ones that cook the food. So we're more exposed to it and we're more vulnerable. We're the first affected. Then secondly, because they have low cost, no money to seek health care, and they don't have that decisions by themselves to go and seek that health care, because there is this autonomy and power that we don't have. And then thirdly, we are more exposed to stigma, discrimination and abandonment.
Does it help to be a woman in your work? Are you able to address issues with female community members that men would not be able to?
Yes, so as a woman in my community, Sagbama, as a health worker, the women that come there, they confide in me. There are things that they cannot open up to men because I'm a fellow woman like them. I'll understand their challenges.
Dr. Coco, why do you feel your work is important?
My work is critical and it is very, very, very important. As a woman and as a medical officer of health, I'm proud to say that I'm a female medical officer of health. In the state, we're four female medical officers of health, and I'm happy that I'm one of them. I'm very important because when I go to some places, I show them that I'm a woman and I'm able to do these things, and therefore their women could also emulate and follow my step and then prevent themselves and prevent their family, and then the society will be a better place for them. So my work is very, very important.
Well, thank you so much to colleagues from Nigeria for that wonderful, inspiring message, particularly from Dr. Coco and medical officers like her. Next, we are thrilled to share a video statement from the Honorable Yolanda Weldeng, Minister of Health for the Republic of South Sudan.
NTDs are common in regions like South Sudan and mostly impact women and children. The consequences of these infections can be lifelong, impairing growth, development, reproductive health and fertility, exacerbation of diseases in pregnancy, and social exclusion and stigma. NTDs affect women in different dimensions, but let me talk about a few of them. Intestinal worms greatly affect women and girls of childbearing age as well as pregnant women. Maternal anemia is worsened by intestinal worms, which are associated with pregnancy complications such as preterm delivery and low birth weight, as many others complications symptoms. Leishmaniasis leads to development of disfiguring lesions, particularly on the face. This can lead to women being stigmatized within their community, reducing their ability to marry and maintain their livelihood. Fears of infection can cause members of the household to limit interaction with those that are impacted, in some cases separating mothers from children. This can lead to further depression and anxiety among women and girls. Access to healthcare for patients suffering from NTDs, which is neglected tropical diseases, especially for women and girls, are a challenge. They are faced generally with barriers to healthcare, such as childcare and other responsibilities may be prohibited seeking care. Additionally, certain cultural norms can dictate whether a woman receive access to healthcare for management of an NTD. Thus, lack of access to appropriate gender-based medical care can contribute to ongoing burdens of NTDs in women and girls. NTDs greatly affect women and girls living in poverty and can have lifelong effects on women's health. I want to recognize and acknowledge the unprecedented contribution of women in the fight against NTDs globally and in South Sudan in particular. We know that women are the most committed community drug distributors and caregivers for NTDs patients. Yet in many cases, women have not been adequately involved in NTD leadership at community, district, national, and even international fora. I am appealing to governments, donors, training and research institutions to create more spaces for women in leadership sector and NTD programs in particular. Women are best caregivers. With the involvement of women in leadership, we shall have got a strong platform to make progress together towards the elimination of NTDs. Further, efforts to reduce the burden of NTDs on women could focus on following areas. 1. Support WASH interventions in the communities to allow women living and working in an environment that reduces the risk of NTDs infections. 2. Increase surveillance of NTDs within the communities with a focus on women health clinic. 3. Implementation and expansion of NTDs elimination program to provide routine administration of deworming medication to children and women of childbearing age consistent with WHO guidelines. 4. Enhancement of culturally appropriate gender-focused health care access for women and girls with increased engagement of healthcare specialists, including obstetrician, gynecologists, family practitioners, pediatricians, midwives, nurses, and other medical professionals with specialization in women's health. 5. Improve education of healthcare provided on the risk of NTDs in women and girls, focusing on disease recognition, available diagnostic tools, management options, and long-term follow-up. I appreciate the organizers of the World International Women's Day focus of the elimination of neglected tropical diseases. And the viewers who are watching this, your support is highly appreciated. And to the donors around the world who are fighting the cause of an elimination of NTDs, thank you so much for your support. This is Yolanda Wilding from South Sudan. Thank you.
Thank you to the Honorable Minister of Health in the Republic of South Sudan. And thank you again for your very specific calls to action in the run-up to International Women's Day. Next, I'm equally excited to welcome Dr. Daniel Aibach, who is the Senior Policy Advisor at the Division for Pandemic Prevention and Preparedness, One Health, at the Federal Ministry for Economic Cooperation and Development, or BMZ, Germany. Dr. Aibach, what is Germany's approach to improving gender equity in global health, and specifically in the fight against NTDs? What must be done to improve gender equity in our area of work, do you think?
Yeah, thank you very much, Gia, and thanks a lot for inviting me to this event. Yeah, dear ladies and gentlemen, dear colleagues, just last week, the German Federal Ministry for Economic Cooperation and Development has launched its new feminist development strategy, which shows our dedication to eliminate structural inequalities, unequal treatment, and discrimination. And I would like to share some thoughts on how the strategy is linked to our already existing approaches to tackle neglected tropical diseases. The German government has been supporting the prevention and control of NTDs for decades, mainly by strengthening national health systems. But with our 2021 One Health strategy, we have embedded intersectoral cooperation and a more holistic approach in our fight against NTDs, which means poverty, inadequate sanitation, close contact with animals and vectors of infectious diseases, which are all underlying factors, are addressed. And this is where the One Health approach comes in, focusing on the interface between human, animal, and the ecosystem in which they live. But this holistic approach must include societies in all their diversity, including women, girls, and members of the LGBTQIA community, and regardless of skin colors or disabilities. Particularly for the health sector, I think it is crucial to connect the human right for health with gender equity and women's rights. Women play a critical role in health systems and in the fight against NTDs. And this is what we just have heard in the first video. On one side, they're often the most affected by the diseases, bear the largest burden of their consequences due to socio-economic factors and stigmatization. And at the same time, they have the least access to medical attention. On the other side, they often act as caregivers and educators in their communities to prevent, treat, and raise awareness for NTDs. And women often do the lion's share of household activities, dealing with children, water, animal, hygiene, and food. Another key role in fighting against NTDs. And the reasons why empowering women through education and economic opportunities contributes to reducing NTDs in their communities. As our new strategy puts it, women are agents of change in the fight against NTDs, but also for other crises. We shouldn't forget crises like climate change or biodiversity or processes of building peace, all crises where women have a crucial role. And as such, we're working on 3 levels. First level is to realize rights, which is a fundamental prerequisite for true equality. Second is our intention to give access to resources, which means equal access to education systems, health systems, social security systems, but also, for example, access to sanitation. And third is to improve representation in all social, political, and economic decision-making processes at all levels and integrated on equal footing. So more concretely, what does it mean? In our ministry intends that over 90% of all the new projects which we are engaging with will contribute directly or indirectly to achieving gender equality. The new BMZ core strategy on health, social protection, and demographic development takes up all those points and makes concrete proposals for strengthening health projects and also social protection system, improved prevention of infectious diseases, and equal access to vaccines, therapeutics, and diagnostics against NTDs. But what we have to keep in mind is that this requires a concerted effort. The issues of NTDs needs to be put back high on the political agenda. We need to strengthen WHO and also other key multilateral partners in their efforts. And we need a new genuine partnership with endemic countries, as laid out in our also quite new, the new Africa strategy from our ministry. And this is why we support WHO's ASPEN program on NTDs with 4 million euros. And we partner with the capacity building program TDR since more than 50 years now. But it's clear that without gender equity, we will not succeed to solve any of those multiple global challenges. And we will definitely fail in achieving the Sustainable Development Goals and the milestones of the WHO NTD roadmap. With this, thank you very much, and I wish you all a great discussion. Thank you.
Thank you so much, Dr. Aibak, for that message. You hit a point, you highlighted 3 points, I think, one about realizing rights, access to resources, and improving representation. And I feel like these 3 points are going to be repeated again or discussed again when we get to the panel discussion component of our programming. So I do hope you'll stay with us and see if there are any questions from the audience that are directed to you. Thank you again. Next, we have a short video statement from Dr. Obiageli Nebe, Director Program Manager for the National Schistosomiasis STH Elimination Program, Federal Ministry of Health, Nigeria. And she's going to help us understand what Nigeria is doing to ensure gender equity in their NTD programming.
Good afternoon, everyone. I'm Dr. Obiageli Nebe, a director and the program manager for the National Schistosomiasis and Soil-Transmitted Helminthiasis Elimination Program, Federal Ministry of Health, Nigeria. I'm delighted to be part of this great webinar on embracing gender equity in the fight against neglected tropical diseases. Nigeria accounts for 25% of the neglected tropical disease burden in Africa. An estimate of about 122 million Nigerians are at risk of at least one NTD, of which women and young girls make a majority. The Nigerian government is committed to ensuring that our people do not have to suffer from easily preventable and treatable diseases. We are also committed to ensuring that no one is left behind, and Nigeria aligns with the 2030 Global Roadmap for the NTDs elimination. I am proud to say that we have just adopted a new master plan for NTDs. In this new plan, which has been endorsed by the Honorable Minister of Health, the goal is to progressively reduce mobility, disability, and mortality due to NTDs using integrated and cost-effective approaches. To improve proper planning on inclusion, NTD data is disaggregated by gender and reports on disability are collected. We are also deeply committed to inclusive services in NTD and all other public health programs. We want to ensure that our services reach the farthest corners of our communities and that nobody is left behind. The current NTD master plan stresses the need for intensifying cross-cutting approaches to improve universal health, like integrating schistosomiasis, especially the female genital schistosomiasis elimination program, into routine services of the primary health care. The NTD program has made deliberate efforts to recruiting female workers in order to improve interventions coverage among young women and girls. On the eve of the International Women's Day 2023, I reaffirm Nigeria's commitment to the NTD roadmap. Our commitment to improving equity and inclusion in our programs. As we celebrate the 2023 International Women's Day, I call on global partners and stakeholders for their support and investments in ending needless suffering from diseases like schistosomiasis and blinding trachoma that affect women and girls. At this point, I want to sincerely thank the organizers of this webinar, and I wish all the women in this room and out there a great celebration in advance. Thank you.
Thank you so much, Dr. Nebe, for reaffirming Nigeria's commitment to the NTD roadmap, vision, and goals. You talked about data disaggregation and gathering data on disabilities, and I believe this point will again come up in the panel discussion when we talk about how we can improve data collection in the context of improving equity. It is my distinct honor now to invite Professor Margaret Japong to help us understand how women and girls are more vulnerable to NTDs and why an investment in the fight against NTDs is also an investment in the empowerment of women and girls. Professor Japong is the director of the Institute of Health Research at the University of Health and Allied Sciences in Ghana. She is a medical anthropologist by training with research interests in health systems, gender, and NTDs. She's recognized globally for championing the cause of women and girls suffering from diseases of poverty, and a mentor to many, many practitioners in this field. Over to you, Professor Japong.
Thank you very much, Rija, and very happy International Women's Day to all the ladies out there. And let me say thank you to the men also out there for supporting us to be able to achieve the things that we are able to achieve as women. I think I'll share my slides now. Yeah. So I was quite intrigued by the presentation from my colleagues in Nigeria, where the practitioners were very forceful and vocal about their interest and their support to work on NTDs. And as I thought about them, I thought about also the women at the lower level who are community drug distributors for many of the NTD programs that happen and some of the challenges that they face as women. And it's something that maybe at another time we can look at the role of frontline workers and volunteers in this fight against NTDs. Gender perspective. So I posed the question, news or no news? And really, we all know that gender actually remains a recognized but relatively unexamined aspect of the challenges for NTDs in infected countries and communities. This statement has been used over the years, and I asked myself, for how long will we continue to use this statement as it's presented in various books. It's really no news, and it's about time we started doing something about it, acting more rather than talking about the issue. So a current global burden of disease study actually has documented that, yes, men do have a greater burden of NTDs, but we see the longer term impact on women, and it's more severe because of the inequities and the lack of power, particularly in low resource settings. And many of these NTDs affect people in very poor settings and the poorest of the poorest in these conditions. Women, as we all know, have limited access to education, health, literacy, land ownership. So actually, they really don't have the voice or the power to be able to do a lot of things when it comes to they being affected or their family members being affected by NTDs. If you take trachoma infection, for example, children under 5 in rural areas can be up as high as about 60 to 90%. And because women are primary caretakers, they are 4 times more likely than men to be permanently blinded by the disease due to the frequency of infection. So their children have it, they are taking care of their children, they are rubbing their eyes at the same time, and they are more likely to get it than men. So why are we more affected? And I'm saying we because I am a woman, and what makes us more vulnerable? We spend quite a lot of our time, our reproductive years pregnant, and another 60% of this time lactating. And for many of treatments, you know, on the packaging is written not to be taken when you are pregnant. So you find out that many women miss these treatments due to pregnancy and breastfeeding, making them very susceptible due to chronic infections. So they keep getting the infections, they keep getting pregnant and are breastfeeding, and so miss the opportunities to receive treatment. But you realize from the literature that many of these MDA treatments are not contraindicated in pregnancy, but still you have people being excluded when they are pregnant or lactating. Then also there's a risk, and my colleague talked about it earlier on, about HAT and leishmaniasis due to the exposure to the kind of work that they do compared to their men. So why are we more affected, and what makes us more vulnerable? Our whole biological and physiological factors leads to increased vulnerability in some of these conditions. If you take female genital schistosomiasis, for example, very unknown, very few people, our health workers or community members know about it, but it affects the whole genital system, from the ovaries to whatever you can think about. And the consequences are really dire for women. My colleague also talked about issues around anemia, and when women have severe helminth infections, the consequences in pregnancy with anemia are also very dire. The sociocultural factors that relate to it, take schistosomiasis, for example, women performing their regular household chores using water bodies because they do not have sources of potable water, get infected, oblivious to the fact that they are just doing their regular work. And then also, as caregivers, I've talked about the issue of trachoma, they getting risk of getting the bacteria into their eyes because they are taking care of sick family members. And it's not only trachoma, it relates to other NTDs as well. So how does it affect the lives of these women? You find out that women are more likely to give up their jobs or to drop out of school to be able to take care of a sick family member. And it doesn't really happen that much for our men. And then it takes to have a long-term negative effect on the economic impact of the family. So if the women are bringing other sources of funds to the family and they've had to give up their jobs because they had to take care of somebody, it reduces the amount of funds that come into the family. We've heard about issues of stigma, so disfigurement and disability, social stigma. They will not get a spouse. Nobody wants to marry them. They cannot go into public places, and so they are excluded and secluded from a lot of activities. We talk about blindness, and once a woman who takes care of the family is blind, we know the consequences of some of these things. So these diseases affect women in quite a number of ways. And once the women are affected, the individuals in the household are affected, and the society is also affected. So what are the economic consequences of having these NTDs? And we all know, I've talked about some of them. I talked earlier on about it being a disease of poverty. And so NTDs perpetuate the cycle of having these conditions, the direct costs associated with diagnosis and treatment. And we know that sometimes women need permission to be able to seek treatment if they don't have their own resources. The indirect costs associated with lost educational potentials, economic activities, and caregiving responsibilities and stigma. So traveling for healthcare, spending time there. Take Buruli ulcer, for instance, it takes several months to get people treated, and they have to stay in health facilities. The consequences on the family are dire. Out-of-pocket treatments result in a lot of financial loss for families, and there were examples found in Ghana and Nigeria. It's not only these two countries, but others. So generally, it also has a significant impact on development in general and productivity. So we are looking at the macro and the micro level at the same time, and these are the consequences of this. So why do we think an investment in the fight against NTDs really is an investment in empowering women? And I borrowed this from a publication. And they're talking about the need to reduce the burden of NTDs. And if you look at all the other indicators that surround this, it relates to some of the issues I talked about. Once we are able to reduce the burden of NTDs and invest in the fight against NTDs, we are able to promote gender inequality and empower women better because they are healthier, they are stronger, they are able to work and get money, and so they become better empowered. We're able to reduce childhood mortality, combat HIV, AIDS, malaria, and other diseases, because these days we are talking about the link between female genital cysto and HIV and stuff like that. Women are healthier, children are healthier, they are able to go to school, stay in school longer, and then be able to achieve better. There's improvement in maternal health. And of course, we are able to eradicate extreme poverty and hunger. And these all lead to the Sustainable Development Goals and ultimately to what we hope to achieve with the new NTD roadmap. And I hope that together we'll be able to work and break down the silos and engage better with partners to be able to fight against NTDs and ensure that our women are empowered. Thank you very much for your attention.
Thank you so much, Professor Jiapong, for that agenda framing presentation. We've noted your points about how the impact of NTDs on women might be higher because of systemic inequities. You also talked about the micro and macro level consequences of NTDs on women's health and economic empowerment. But finally, you also highlighted how reducing the burden of NTDs will have positive knock-on effects on poverty, childhood mortality, HIV, education, and maternal health. And I think these points will keep coming up again during the live panel discussion. So I do hope you'll stay on for the Q&A component. So up until now, we've heard from leaders of national governments like Nigeria, South Sudan, and Germany. And Professor Jiapong's talk has framed our understanding of gender inequity in the context of NTDs. Professor Jiapong, your overview provides an excellent segue into the next segment of our program today, which is a conversation with some leading thinkers, practitioners, and advocates working to advance gender and equity in global health and NTDs work. I will invite our panelists to turn their videos on if they haven't already done so. And as they turn their videos on, I will do a brief round of introductions of our panelists. I will kick off with an introduction to Ms. Nisan Zerai first. Ms. Zerai is the country director for Nala Foundation in Ethiopia since 2020. Nisan has over 15 years of experience with various NGOs across several countries around the world. Her expertise includes public health program management, advocacy, policy, and research. She has worked extensively on gender and health equity, and Nisan holds degrees in law, specializing in human rights, reproductive, and sexual health rights. Welcome, Nisan. Next, I present Ms. Fionn Storer-Jones, who's the Advocacy Officer, Global Health Research and Innovation at DSW in Brussels, based in Brussels. Ms. Jones leads DSW's work on gender equality in research and innovation. Fionn has an active interest in the social dimensions of health and the intersection of human and planetary health. She holds a degree in medical physiology from the University of East London. DSW has recently published a renewed study on poverty-related and neglected diseases through a gender lens, from which Fionn will share some findings later. Our third panelist joining us from Bangalore, India, is Ms. Jayashree Kunju, who's the CEO of IBAS Global, a company providing coaching and training for accounting professionals. As a board member of Charities That Work for Leprosy, Ms. Kunju is actively engaged in supporting the global community of people affected by leprosy to ensure that people affected by the disease are respected, supported, treated, and rehabilitated. Jayashree is a board member of IDEA, the International Association for Integration, Dignity, and Economic Advancement, and a trustee of the Global Alliance for Zero Stigma. She's also a published poet. Thank you to all three of you for making the time to be with us today. I have three questions that I'd like to ask each of you. Two are common and one is specific to your expertise and experience. At the end of the guided discussion, we will open the floor for a brief Q&A with our audience. Let me start with you, Nisan. What must happen, do you think, to achieve more gender equity in the fight against NTDs?
Thank you, Gurja, and thank you for having me on this panel. I'll just say a couple of things about what was already said to get to the point where what needs to be done. So we have agreed, and many of the speakers have raised, that NTDs by definition are disease of the poor, and women are amongst the poorest in society. So even from the start, we have them more affected by NTDs. And then they're also disproportionately affected by the diseases for reasons such as the allocated role they have been given by society as the main caregivers of children, which expose them to some of the NTDs. We have society also giving them the role of probably water collectors from rivers. 2/3 of water collection in rural settings is done by women, which makes them more exposed to some NTDs like schistosomiasis. Women also have lower access to healthcare. This could be for different reasons. They have little or no decision-making power in the family. Healthcare centers are located in areas that they do not feel safe to access. Whatever the cases, throughout their life, they're facing obstacles in accessing healthcare. And then when they're affected by the diseases, the impact is way more harmful on women. It affects their reproductive outcome, as been said. Disabilities caused by diseases such as elephantiasis has an impact on their livelihood because of a decrease of marriageability or their ability to be hired, and significantly affecting them, leaving them trapped in abject poverty. So when we are talking about NTD programs, we need to stop designing interventions or having policies that are gender blind. Every time we're developing a policy or thinking of an intervention, we need to think that how that will impact women and how accessible it would be for them, despite all the known factors that probably we couldn't address in the NTD programs that will hinder them from benefiting from them. Thank you.
Thank you so much, Nisan. I think you've just about whetted our appetite with what more needs to happen. You talked about gender blind programming and how we need to start looking at the gendered aspects of the impact of NTDs right at the design stage. Over to you, Fionn, with the same question, please.
Well, firstly, thank you so much for having me as part of this webinar. I think I would elaborate on what Nisan had said, and we really need to eradicate gender blindness from our work on neglected tropical diseases. And this needs to go back to the bench side. I think that there are biases and discriminations at the very early stages of research that perpetuate the inequalities that we see. And one of the recommendations of our study is the need to better collect sex and gender disaggregated data. So in order for us to eradicate this blindness from our work, whether that's from a programmatic point of view, from a policy, or from a research point of view, when we don't have the data, we are unable to really consider what needs to be done. Also, we're not able to measure effectively, and so we cannot progress well. So this is really not a new recommendation, and we stress this in our study. This has been made over and over again, but we felt that it was really important. And I would say that we cannot make effective changes if we do not have the data, and our decision making is not driven by data.
Thank you so much, Fionn. Eradicate gender blindness in programming. I really like that powerful statement. Over to you, Jayashree, to see if you'd like to step in here and add some of your thoughts as well. And you're muted, Jayashree.
Absolutely sorry, I'm back. Thank you, Girija, and thank you, my panelists, other panelists who have covered the critical aspects. And we are looking at, how do we achieve the gender equity? Firstly, like my other panelists said, it's basically to know the difference. Like women are, by virtue of the gender, disadvantaged. And then we're looking at how do we achieve equity. It is, bringing all the players together to make them understand that this is the reality. There is inequity. The first thing is to realize there is inequity, and to get, the main players, the stakeholders, apart from the people themselves affected, the stakeholders like, say, the policymakers, the charity, the NGOs, the police, the other players in the government, the United Nations, all the various departments, to get that there is a difference, there is inequity, and then to look at what could be the creative way that we address the inequity, and then create a solution. So basically getting the constituents together to, on the same page, across, the same table, and sitting and looking at what might be the reason why the inequity continues to be so. And with all these changes that's happening around the world, how come, this is not an area that's been addressed? So we need to take a hard look, get everybody together firstly, and then, maybe brainstorm and look at what may be the way to go forward. So I think it's about getting together for one. Yeah, thank you.
Thank you. Thank you so much, Jayashree, for that. I think all three of you have highlighted this one particular point, which is recognizing that there is a problem in our programming is the first step, particularly when it comes to, what did you call it, Fionn? You called it gender blindness in programming. And Jayashree, you made the point that bringing the key stakeholders together would be a first step. Let me ask you a couple of pointed questions then. Over to you, Nisan. How do NTD interventions have to be designed then to be inclusive and reach women and girls with and without disabilities?
Thank you, Girija. So NTD programs have to be redesigned with women in mind. That's an absolute fact. Every aspect of a program that we're designing, from the consultative process to the MNE, should consider the unique aspects of the society that is most affected by the disease. If we have agreed from the outset that NTDs disproportionately affect women, we need to consider how programs are having an impact on them. Therefore, we have to have a concerted plus an intentional effort to ensure the design and delivery of NTD programs is seen through the gender equity lens. So when we're designing programs, we're talking about the initial stage, we're talking about the implementation and the MA. For instance, in our case, when we're starting any project or program, even before designing it, we have a consultative process with the community that we are going to work with. This could be discussing the program or the project we're thinking with the local authorities, school principals, teachers, community influencers, etc. When we are doing this, we need to stop and think if women were well represented in this process. Has there been enough women that could reflect the 50% plus in most cases of the population that we are there to work with or support? In many instances, what we see is that women are not well represented in decision making. In that case, even having a consultative process, we're going to miss the views in the initial planning itself of the consultative process, which in turn means that we're designing something that hasn't considered women at all, women with disabilities, women without disabilities. And then we are ending up with projects and programs that probably wouldn't have as meaningful impact on women and girls in that community. And then when we implement the programs, our implementation plan has to ensure that the intervention is accessible, both in terms of gender and disability. For instance, let's say we have an MDA company, we have the medicine, we have all the logistics figured out, and have centers for the drug administration. Have we considered if the terrain is actually accessible for women to travel to, and those with disabilities, for instance? Is there any social barrier for women to travel to these locations? Is it planned at a time when women can actually come to the centers? Have we considered that? If I will give you an example, in Ethiopia, for instance, Ethiopia, the Ministry of Health is scaling up the national deworming program from a school-based MDAs to a community-based MDAs. However, on this round only, because of the lack of resources, we are only targeting women of reproductive age. So we have to stop and think, and because it's a well-known fact in our community that if we're targeting women for any medical intervention, that is considered a bit suspicious. Are you trying to control the population? Are you trying to sterilize our women? Unless the program acknowledges this from the outset and work on it when doing the social mobilization, community sensitization stage, we're going to have a very low coverage of MDA, despite all the planning, all the logistics being in place. I can give you another example. For instance, we are designing a behavioral change intervention. We have to stop and think, are we reaching women and girls with this behavioral change intervention? Let's see what the literacy rate of women and girls is in that community. If we have seen that the literacy rate of women and girls is low in the community and we're distributing written materials, we're losing this group. So we need to think, how do we tailor it to fit women and girls in general and those with disabilities in particular? We can't be developing NTD programs without considering those with disabilities, for instance, because the consequence of most NTDs is disability. If we have a trachoma project that doesn't consider people with blindness, it's actually not going to be effective, whether it's on accessibility for treatment or providing materials in Braille. Disabilities have to be factored in the program as well. So the intersectionality has to be considered here. And when we talk about monitoring and evaluation, we have to ensure that sex and disability disaggregated data is collected. Not just collected, but used. The emphasis on the use will be there. We need to try to learn from what the data is telling us. We're not just collecting for the sake of collecting. And then once we have the numbers, we have to see beyond the numbers and say, why? Why are the disparities? So we have to have a gendered analysis of the numbers. So once we have the data and the analysis, we also have to be able to tweak our ongoing programs, if that's possible, to make them more impactful, or use that for input for future programs that we're designing.
Excellent. Thank you so much, Nisan, for that. You hit upon so many sort of very practical things to consider when designing program, including whether or not it's one thing to have a consultative process. It's another thing entirely to ensure that the consultative process actually includes women in the consultation. And you made a great point about learning from data, not just collecting data and learning from data. So I think this is an excellent way to sort of get to Fionn next, to talk about how can research and data disaggregation help to address inequalities. And Fionn, please do feel free to draw from the recent study that you supported at DSW.
Yes, so as I said, the importance of collecting, and as Nissan stressed, making data available is one of the recommendations of our study. And I think I would just step back one moment just to say that many speakers have been highlighting that prevalence data alone doesn't capture the broader impact of neglected tropical diseases on women and girls. And this is really at the core of our study, showing the need not only to consider prevalence, but also impact in the research and innovation of new tools to tackle these diseases. Research and innovation is historically male-centric, and we are not doing very well to consider sex differences on a biological level, let alone the broader gender dimension of diseases. Health is a social, is determined by social aspects hugely, and we are blind to those often in the research and innovation of new tools. So our new study has put forward a visual that I would encourage people to take a look at, that aims to show the changes that are needed right across the research and innovation cycle, from the early stages by the bench slide to regulation, to regulatory considerations, and also in the dissemination of new tools. But if we were to look very early in those stages, the need to use both male and female cells, in the early phases of research, around 75% of research articles do not report on the sex of the cells used in studies, and where they are reported, female cells account for only 5% of the cells used. We are aware, and I think COVID-19, the pandemic, has amplified the lack of diversity in clinical trials. So again, a very historically male-centric stage of the research and innovation cycle, and we must do better to have the populations most affected by diseases represented in clinical trials. This is especially pertinent for pregnant people, historically excluded from clinical trials. And a previous speaker highlighted the challenges of having a lack of safety data and efficacy data for tools for pregnant people leads to their exclusion. We may have products available for certain diseases, but there is fear of using them because of the lack of data available. So including pregnant people in an ethically sound way is incredibly important to ensure that all populations, often populations that are at risk of more severe or very specific form of diseases, are included in that process. If we were to look at the other side of the bench side, so to speak, to look at who's doing the research, this is also a very important topic and a recommendation in our study. We've heard about the need to have more women in leadership, in setting policies, in driving programs. This is also true for research. We recently marked International Day of Women and Girls in Science last month, and we know globally only a third of researchers are women, and this varies in different parts of the world, but still the people doing the research as well as the people being researched do not represent our societies. We know that when women lead research teams, when they are in decision-making positions within research teams, they do better at considering sex and gender. So this is also an important recommendation that we've put forward in the study. There are many recommendations. I don't want to go over time, but I think an important point to make is that the recommendations we've put forward, they require change. We need to make change. We have gender blindness, as I said. Often we have knowledge biases because we haven't been inclusive in the way that we've been doing research. And so in order to make these changes and in order to perhaps even correct some of the biases that exist because of the the exclusive nature of our research, we will need money, we will need commitment. So more funding is needed to fill these gender gaps in our research and innovation, to correct some of perhaps the misconceptions that we have about the tools that we have. And we need funders. We need medical journals, we need governments to step up and really to make sure that they are requiring sex and gender considerations in the research that they're funding. This means also building the capacities of teams to be able to consider this in the research. And so it really needs everyone that's involved in the research and innovation process to be working together to ensure that all of these stages work together so that the tools that we are creating are really working for everyone, and also not perhaps, which is the case at the moment, also driving some inequalities.
Thank you for that, Fiona. I think your last point about bringing all stakeholders together harkens back to Jayashree's point as well. And you made another really important point about, what gets researched is also a function of who is doing and leading the research. I think that's an excellent point. Thank you for that. Jayashree, over to you. Can you sort of bring it down to sort of the person, the individual experiential level, if you can? What kind of experiences do affected or women living with NTDs or leprosy have? And why is fighting NTDs a contribution to their empowerment? Can you please speak from your expertise and experience, please?
Thank you. Yes, so women affected by NTDs, firstly, don't count in the scheme of things for many reasons. Firstly, they're disadvantaged as mostly they're homebound, mostly not educated, and mostly not mobile. So, and also they're not even looked at as economic contributors, because generally in a very impoverished environment, a woman's role is about, managing the hearth and the home. And anyway, they don't count politically because they're not contributors to the nation's GDP. And if they are lucky, they may have an empathizer or two in their families. And the first experience that they have is that of separation. So I have heard cases where the utensils used for eating, the clothing, the bedding are kept separate. And slowly communication starts, the level of communication starts dropping. There's minimal interaction with the person affected. And also many of them, because of the long period of medication, go through side effects. That can have a debilitating impact psychologically, of course, physically. And the agony is aggravated because sometimes caregivers give up, and there have been cases of caregivers' violence towards people who are going through this. And mostly violence against women are not reported because perpetrators are stronger people, and just communicating about this to anybody within their community can have negative, impact. So there's another aspect. And also the patient, because of lack of, say, medical attention, might even end up overdosing or not taking the proper dosage of medication, probably overdosing on painkillers because that gives them some kind of, comfort, sleeping pills. And many of them talk about having been suicidal. Like they've survived. Many of them, of course, survive, but then they live a less, fulfilled life. And there are additional issues for women of menstruation, personal hygiene. And we're talking about people whose access to water and sanitation is poor. And then, I've come across a case of a girl going for a double amputation. The kind of understanding the hospital probably did not have was to give a room to her, and she was pregnant soon with a husband who left her after the baby was born, and her legs are also, like she's been amputated. So all these things added to the fact that there is no integrated health services. So one must imagine what happens to a woman who is pregnant and has to go to a hospital where she may not most likely be treated well because of her conditions. And there are also cases where the admission to the hospitals have been denied because of the conditions. So these are some of the things. And under all these circumstances, these women definitely need an agency to, give them hope required to carry on. And at times, the hope comes from the health worker who's been, sensitized to their situation and who saves them. And many times, it's a marriage to a partner who is willing to take a stand for the person. And mostly these, marriages happen within the affected communities. Like, for example, a leprosy affected person takes on marrying the woman. And then, the empathy comes easily for people who have gone through the similar circumstances. And of course, NGOs play a very big role, and the frontline workers, healthcare workers play a big role, and NGOs play a big role in mainstreaming these people. And I have had so many interactions with women who have had this kind of support. Maybe they started off tentatively, but with the right support, these are people who took on the corporate in their locality, mostly men. And they failed. When they came back, and then they fought back. And then what I see is that these are women who become role models. And the best part about this is that becoming role models for their own girl child, and also for women in their own community. So I've seen one empowered woman, impacting a minimum of 1,000 other women. So that's the power that they can get out of, having a role model within their community. And that could be the strength, that they can give back to their communities. Thank you.
Thank you. Thank you so much, Jayashree. That's really empowering. Well, thank you first for helping us understand what it feels at an individual level to have that burden of disease and to feel neglected by your immediate community. But thank you also for highlighting how there is still power within the community, how health workers can advance, empowerment, and how the disability community can itself be a source of strength and empowerment for women living with the effects of NTDs. Let me take this moment to quickly remind our webinar participants, to add your questions using the Q&A button on the bottom of your screens to any panelist or any one of our speakers here today. If possible, please indicate which panelist you would like to answer your question. Now, let me circle back again to Nissan first on your sort of closing comments, if you will, Nissan. Reflecting on what Jayashree and Fionn and others have also spoken here today. What is your message to the global NTD community on International Women's Day? Over to you, Nissan.
Thanks, Gurjan. Well, from what has been said so far, I think if we're fighting NTDs, and when we're fighting NTDs, women have to be at the heart of the programs that we're designing and implementing. We have to move from using tokenistic gestures, like a question on a funding application about how you have considered gender or disability, or having a couple of women in your programs. We need to have a very comprehensive gender and NTD working framework that could be used in all aspects of our work, whether it's government level, within the donor community, or implementing partners. The 2030 Agenda for Sustainable Development emphasize the importance of ensuring equitable health outcomes and healthcare delivery to all. So having a gender-sensitive approach in everything that we do, and the principle of leaving no one behind, should be governing all the steps that we're taking in this it's a winnable fight of eradicating NTD.
Thank you. Thank you for that powerful message, Nissan. Over to you, Fionn.
Thanks. I think for me, as we approach International Women's Day, and the focus this year is on innovation and technology for gender equality, I think I would stress that when we are talking about the need to deliver gender equality in our approach to tackling neglected tropical diseases, that we don't forget about research and innovation. I think it's something that perhaps happens far away from our daily lives, but we benefit from the results of research and innovation every day. And particularly in this area of health, where so many neglected tropical diseases are still missing tools, diagnostics, vaccines, therapeutics. How can we be researching for new tools for these diseases when we are neglecting some of the populations most affected in that process? So I think my message would be that there needs to be an investment in a more inclusive research and innovation process. And while some may say, that comes at a cost, I think the true cost is in failing to be inclusive. For the research will not be helpful if we're only, for example, using males in our research. So let us not think of having inclusive research and innovation as a burden or as a cost, but really as an investment in truly being able to tackle neglected tropical diseases in an inclusive way for women and for our societies.
Lovely, thank you for that. Nissan spoke about moving away from mere tokenisms in gender-sensitive programming, and Fionn, you're talking about centering women and gender in research and innovation. Thank you for that. Over to you, Jayashree, for your closing thoughts before we open to Q&A.
Yeah, thank you. I think my other panelists have already spoken, but just want to add a little bit. Integrate the policies to be developed with the inputs from women for the direct stakeholders themselves. So, it's very difficult. One might say they don't have communication skills or they don't know what their rights are, but believe me, they all know their rights. So include them, somehow find a way out, nationally, include them in the political and legal processes, which might help them to get their rights, access their rights more easily. Because I've noticed with the economic empowerment, the conditions start altering and they find out their voices. So prioritize provision of basic dignity, provide them with whatever is required to have their dignity intact. And also there are international conventions like CRPD, but they need to be properly implemented. So the kind of, the political will that is required has to be brought to the forefront, that something must be missing, and what's missing has to be brought in. And also the domestic legislation therefore should be enacted, and maybe communication, documentaries and films, etc., to change the attitude of the public or the police and others stakeholders who should directly be involved in dealing with the fears that they have about people, and that's the way you can protect the women. And of course, some countries may have this special cells for women with disabilities or with NTDs, so that they can go and report abuses and feel more protected. So some of these things should be taken care of. Thank you.
Lovely. Thank you for that, Jersey. You talked about inclusion in the policy dialogue at the national level and subnational levels, and really changing how women with disabilities are even portrayed in media, and engaging stakeholders at all levels. So point well noted. Thank you so much again for your insights and observations. I'm going to step into the Q&A box, and I'm going to see if there are any questions that are directed to any panelist here. Let me start with this. How do the panelists and speakers think NTD projects and post-treatment social inclusion, which is education, economic empowerment, and advocacy can be integrated together. Let me see if Nissan or Professor Japong would be interested in responding to this question. Nissan, would you like to have a go at it? The question is integration of NTD core projects with social inclusion, education, economic empowerment. Do you have any thoughts on that?
Well, I'll try. NTD is interlinked with so many other social issues. We're talking about poverty, we're talking about disability, we're talking about healthcare access and the like. So once we have, especially because the person who asked this question also talked about post-treatment, when we're talking about NTD programs, sometimes we're just talking about the treatment angle of it. Then we have to have all the surrounding issues around access to economic empowerment. For instance, in Ethiopia, one of the things that starting now is sanitation marketing. We're talking about personal and environmental hygiene, while we're also talking about people having to produce sanitation materials to also sell, to have some kind of an economic benefit from it while we're doing the same thing. So I think I agree, treatment alone without behavioral change intervention, without economic empowerment on the side and thinking about a holistic approach to the problems, we cannot just give antibiotics. We cannot just be treating, and people are still going back to the economic situation they are in and being reinfected and the like. So I totally agree. NTD projects have to think beyond treatment to all the other things that contribute to the infection and the problems themselves.
Thank you, Nissan. I'm going to do a quick check around the virtual room to see if any other panelist has their mic open. I'll continue on. Let me throw this question to Fionn. Fionn, you have a question about how the findings from your study have been received, and if you have any practical suggestions for how to flow back data into programming.
Yes, so at DSW, we don't do any biomedical research ourselves, but we work with a number of partners that do, and I would really recommend maybe reaching out to some of them. I know that MMV, DNDi are really considering sex and gender in their research and innovation work, and I think that they would be happy to share some of their findings there. But what I could maybe speak to is our work using the findings of the study in our advocacy, and particularly perhaps the engagement of European decision makers with the study. I'm based in Brussels, and I'm advocating towards the European Commission, and we've seen change there, and we've seen the leadership really driving forward the consideration of sex and gender in the research that they fund. So the European Commission has made having a gender equality plan a requirement to receive funding from their research framework program Horizon Europe. And this is really a great step forward. So I think we're really seeing this change coming from funders, from policymakers. I think it was Nissan that said that it shouldn't be a tick box exercise on grant funding proposals, and we're also very aware of this, and so we are very interested to see how these gender equality plans really drive forward, systemic change, systemic consideration of sex and gender in research. So I think the study has really resonated with decision makers who are working to drive forward this change. But I think as advocates, our role is still very much there to make sure that this is not another tick box, and that we are really changing the culture of research innovation, and really changing systemically the way we're going about undertaking research and innovation in this area.
Thank you for that, Fionn. I see that the panelists are also responding to some of the audience's questions. through the Q&A feature. So many thanks for that to you, Jayashree, for responding to a question. Let's see, I'm just going to take 1 minute or just a couple of more minutes to ask this question of Nissan. And I think, Nissan, this is something that is of interest to so many of us in this particular sector. And maybe it's a little provocative, and that's perfectly okay, I think. How can we encourage country directors and senior managers who are often older men with traditional values to apply gender equity in their policies and practices?
Thanks, Gurjan. Thanks, the person who asked this. I mean, I don't think it's just a unique thing to the NTD sector. It's across many sectors that we have. For me, it's all like the bottom-down approach or top-down approach works. We have to start making it a requirement. We can't just talk about it as a problem and just leave it. So it could be the donor community that says we require a certain amount of, when you're designing the programs, what has been done has to have a gender sensitivity. It has to be seen through the equity, gender equity lens. We have to have governments that are signatories of so many international women's rights treaties that would say all our policies have to include gender in them. We have a strategy, an NTD strategy, then a government strategy have to have a very meaningful, intentional, not just, as I say, tokenistic or tick box exercise like Fiona was saying. And we have to have that requirement until people are learning this process. When the majority or people in power are not going to give their power like that, it's a comfortable place to be. Like, if you don't know the struggle that women are going through, as a man, probably you wouldn't even, it's not intentional. You wouldn't even consider that this is an issue. So we have to continuously push this agenda, and we need women, more women in leadership positions. One of the, when I was preparing for this event, one of the things that I was considering is in a country like Ethiopia, where we have so many women health workers, thousands of them across the country. The moment you step out of that community level and go to leadership level, you don't see any women. Those positions are populated by men. It's not like we don't have women who have gone through the ranks to actually do this work effectively. We just preserve these roles of leadership for men. And that has been a societal structure that people have been comfortable with for centuries. So we need to be talking about it. We need to be trying to even have a top-down approach of requiring countries, requiring organizations to consider that when we are allowing our funding to be used or our resources to be used by the organization.
Lovely, really powerful indeed, Nissan. The point you made about how a position of power is a comfortable position to be in, and we need an intentional top-down approach to make change happen. Wow, this has been hugely energizing and inspiring for me, and I hope the audience have also feel similarly. We've talked about eradicating gender blindness from programming. We've talked about moving away from tokenism and tick boxes. Jayashree made the point about inclusion in policy dialogue, and really about listening to women and not underestimating women living with disabilities. On behalf of my colleagues at CBM, I'd like to thank our esteemed panelists and keynote speakers for sharing their insights and experiences with us today. Many thanks also to the webinar participants for making the time to be with us today. I see several more questions that have popped up in the last 5 minutes, and I apologize if we're not able to address them live, but we will be sure to take these questions and post them to the individual panelists to the extent that we can. If you're able to stay with us for just a few more minutes, we'd love to play a video message, again from Nigeria, from health workers who make up the backbone of NTD services. Thank you so much again, everybody.
What do you think still needs to be done in terms of NTD elimination?
The agency should collaborate in terms of this feeding for enrolled and non-enrolled children. Example like the Fulani or the farmers. There are some people that will go to farm till after 1 month, 2 months, 3 months, they will be in the farm. So their children are not schooling. So if NTD drops, we reach those rural areas.
Yes, so there are a lot to be done regarding NTD. So we'll clean the dangers of the government, the partners, especially CBM, Christian Blind Mission, to assist our people with their continuation of this, their treatment they've started, and also the nihilists of aliphathitis and hydrosis, the answer to lines during the program, so that they can do operation for them. And also, the government should bring some program for poverty alleviation for our people to be free from neglected tropical diseases. Thank you.
As a healthcare service provider, and to all our partners, CBM and State Ministry of Health, I am pleading with them to continue innovative and intensified disease management like free and safe surgical operations to all hydrocell conditions, provision of safe water to where they are needed, adequate fund availability to how to reach settlements, and also payment of CBDs should also be considered even in this time. Thank you.
We still need to sensitize our mothers, our families, our communities in this condition, because we still have the cases, see these cases in the communities in the rural areas. So sensitization is very, very key. Sensitizing them to come to use the facilities early enough, even before they have complications. Then secondly, there's still need for medications or drugs to be made available all around the year. Then we have hard to reach areas, and areas that are not in the center, and then we still need to reach those communities, those rural areas, to meet the people, educate them, sensitize them, and then give them these medications. And then talking about treatment, it's critical that most of these people, even when we find them, we give them the medications, they still need treatment. They still need surgery to do some corrections. They still need some further treatment to make sure that the deformity and the disability, they have some support, social support, community support, family support, and then this will make them come out of it, and then make them come out and interact with the society more. So these are areas that we still need work to be done, and I believe this can be done if there is funding, if there is partnership, if there are NGOs that are coming to also help in this area.